Good evening, everyone. If you could all just take your seats, please, and we might just get started. So my name's Dr. Alex Mishev. I'm a GP with the COVID Care at Home team at Canberra Health Services. It's good to have you all here tonight. I might just start with an acknowledgement of country. So I begin tonight by acknowledging the traditional owners of the land on which we meet, the Ngunnawal people, and pay my respects to their elders, past, present, and emerging. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. So tonight we're going to have a bit of a talk from a few people from the Canberra Health Services and the community, talking about COVID-19 and the new antivirals that we have for treatment. First, we're going to start with Dr. Anurag Aurora. He is a specialist here at Canberra Hospital. Dr. Arora is a staff specialist at the Canberra Hospital in the Department of Respiratory and General Medicine, and recently has been working as the SPOC, which is the specialist on call for COVID. He holds dual specialization in general and acute care medicine, along with respiratory medicine. He completed his primary degree in India and most of his specialized training here in Canberra. He's passionate about holistic patient care and health literacy and a strong advocate for teaming up with primary care and primary care providers to achieve that. So we might give you a bit of time to have a seat and enjoy the bread and have a chat, and then we'll bring Dr. Aurora up in a few minutes' time. If we could all have a round of applause for Dr. Anurag Aurora.
Hello. Good evening, everyone. This is Anurag here. I'm from Canberra Hospital. I might have met a few of you beforehand. Thanks, everyone, for coming here, and thanks to the organizers for organizing such wonderful event. I'm glad to have this opportunity to talk about COVID-19 medications. I've been working as this point of contact COVID consultant in Canberra Hospital for the last couple of months. So I came across a lot of phone calls from everywhere. So just try to cover a few things. And if you have any questions, it's all about answering your questions so that you guys can facilitate and streamline the treatment. And so that you feel confident, yes, we can do it. And if there are any concerns or questions around it, please feel free. So you can hear. So now a little bit of the background. This is the WHO data. COVID is not gone. It's not going anywhere. Okay, then look at the spike, look at how many spikes we have, and this is just this year. We're talking about this year. So on the left hand side, you have the cases. We're talking about millions. Okay, so we're still talking around 2.5 million everyday cases around the world, and on the right hand side, you have the deaths. So we still have around 15,000 deaths from COVID happening every day. So this is the data that is being recorded. There's a lot of data from a lot of countries. People have stopped doing COVID. I'm from India, and like my friends say, oh, everything's good. People are still going for weddings, 3,000, 4,000 people coming at the same period of time. So few places, COVID's gone. People don't worry about it. In Australia, so next slide here. So now this is COVID-19 deaths per 100,000 population by countries. So you can see the darker it is, the more deaths we have. So the data shows Australia is not green. So we are reporting a lot of COVID-19 related deaths in Australia. So that's what I'm saying. COVID's not gone. It's here. It's going to stay here. So we have to feel confident to treat it and to deal with it. A little bit of background statistics from Australian Bureau of Statistics. So this is, again, as you all know, the age group that is compromised most by COVID is people who are in 70s to 90s. Okay, so that's where we have to be really careful, and that's where we have to be very proactive to start this COVID-19 oral antiviral medications in the community so that they don't end up in hospital. So this is most commonly acute disease outcome of COVID-19. So when they have COVID-19, most of the people have pneumonias, then they have respiratory failures, other infections, renal complications. So then pre-existing chronic conditions. So these are the risk category people who have high risk of having COVID-related acute pneumonitis, ending up in hospital, having high mortality and morbidity. So chronic cardiac conditions. So if you have, I'll go through the whole flow chart. So just start thinking about it. Elderly population, chronic cardiac conditions, dementia. They are from nursing home. They are from residential aged care facilities. High risk. So alarm bell goes on. These are the population. This is the population which would need preemptive treatment with antivirals for COVID. So cardiac conditions, dementia, diabetes, chronic respiratory conditions, including asthma, severe asthma, COPDs, bronchiectasis, chronic kidney disease, hypertension. So these are the main things. Most of the population, they have Parkinson's disease, they have underlying dementia, they all come in high risk category for this. So most common underlying cause in COVID-19 related deaths. So these are the patients, they are not dying from COVID. Okay, they are dying, the number of deaths will differ. So includes underlying cause in COVID-19 related deaths. So these patients have concomitant cancers or dementias and falls and diabetes relating to that. Now, talking about variants, since COVID has started, there have been a lot of variants. It mainly comes from WHO. So WHO is running this whole business of which variant is the variant of concern. We call this is a term, VOC, variant of concern. And as the viruses, they mutate because they are mutating because they're spreading in a big community and they tend to mutate. And WHO right now, we have 13 named variants of SARS-CoV-19. So 13 are variants of concern. There have been hundreds of variants coming around. So Alpha, which was first started in UK, Beta was in South Africa, Delta was in India, Gamma was in Brazil, and Omicron was first found in South Africa. So this is the Australian data. So Australian work is done by Communicable Diseases Genomic Network. So they look after all the genomic sequences. So all these overseas people coming to Australia, coming of different countries, and that's where initially we have been checking the sequencing. Oh, whether this is Delta, whether this is not Delta, whether this is Omicron, whether this is not Omicron. So they have been doing all this work behind the screen, and they have come up with these terms of variants of concern, variants of interest, and variants under monitoring. So Delta is now not the variant of concern because the prevalence of Delta has gone down significantly. And when we are doing the genomic sequences, we are not finding much of Delta at all. So now it's Omicron. So the current variant of concern in Australia is Omicron, which is B.1.1.5 to 9. And it has got a lot of sublineages as well. But for our understanding, we'll keep it simple and we'll just say Omicron B.1.1.5 to 9. So as I said, this started in South Africa in November 21, and WHO tagged it as variant of concern in November 21, and it's got more than 30 mutations in itself. So definition of disease. So we'll come to how to assess, how to quantify people who needs treatment for. We have to segregate the population that needs treatment, population that just needs monitoring. So mild disease. So individuals with no clinical features of moderate or more severe disease, and they have just mild symptoms, which could be fever, cough, sore throat, malaise, headache, muscle pain, nausea, vomiting, diarrhea, loss of taste and smell. They don't have any new dyspnea, and they don't have any evidence of lower respiratory tract infections. Moderate disease, patients are still stable. Patients are still saturating more than 92% on oxygen. But if they do any exertion, they do desaturate, or we see on imaging, we see changes of some COVID pneumonitis, bilateral infiltrates, ground glass changes. So severe disease, people who are in respiratory distress. So their respiratory rate is more than 30, they're requiring oxygen, they are desaturating to less than 92%, and they have lung infiltrates. Now, critical illness. So critical illness, you guys don't see, they come to hospital by ambulance. So they're in severe respiratory distress. So in ICU, we have PaO2 FiO2 ratio that we check to assess whether people have acute respiratory distress syndrome. So the same criteria of PaO2 FiO2 is used for COVID pneumonitis related acute respiratory distress syndrome, where the ratio is less than 200, which tells us that this patient is actually nearing acute respiratory distress syndrome secondary to COVID. So they're requiring high flow, they are in shock, hypertension, and loss of consciousness and multi-organ failure. So now, I'm sorry, this is not very clean, but this slide tells us the population at risk. So I'll just verbalize this for you. So the population at maximum risk is immunocompromised population. So I will tell you what is the definition of immunocompromised population in my next slide. After immunocompromised population, irrespective of their vaccination status, they are top of the list. After immunocompromised population, we come to Aboriginal population. Aboriginal population, unvaccinated Aboriginal population with comorbidities. Comorbidities might include respiratory conditions, underlying neurological conditions, whether they are from nursing home, whether they have some dementia, Parkinson's. So these comorbidities make them high risk. So just going through the table, the group that does not need acute attention is our general population. They are fully vaccinated and they don't have comorbidities and they're less than 65 years of age. So that is the population we can just monitor. So I think this is a little bit clear here. Same thing, I have put it in a schematic order. So I have tried to put in a lot of information from the living guidelines, and I'll show you the link of the living guidelines as well. I do get this question, oh, where did you get this information from? All the information is on the living guideline, and I'll show you the flow charts as well. You can have a look at the flow charts. Information is going to be very handy there. So you have immunocompromised or unvaccinated population, then they are within 5 days of their symptom onset, straight away they go on oral antiviral. We don't have to think about it. Now, some population within 7 days. So all the studies have been done. So right now we have 2 oral antivirals in Australia and these 2 are on PBS. So that's where we're talking to all the healthcare professionals to start treatment. So you can just do your authority streamline script. I'll show you the numbers and codes as well, and how to do these ones. So molnupiravir and Paxlovid. So Paxlovid is a combination of nirmatrelvir and ritonavir. It's got 2 antivirals in that. So if you have a patient, you have to make sure that they come to you within 5 days of symptom onset. That's where you start the treatment. And the evidence is it's all about, they have the first 7 days where they have this coryzal illness, runny nose, watery eyes, sore throat. After 7 days, 5 to 7 days, they go into the interleukin storm phase. So that interleukin storm phase is where they start to develop inflammation in the lungs. So we have to hit them hard in the first 5 days where we can reduce the viral load so that they don't get into that interleukin storm phase. So that's the whole point of starting this treatment within 5 days. So I'll have better slides. So why do we start it? Goals of therapy for outpatient. So main thing is to avoid the disease progression, to avoid hospitalizations, to avoid morbidity and mortality. What factors I use to determine the recommendation? So clinical efficacy, all these data, all the literature, all the research that has been done. I've got this slide from WHO. So WHO theory is, it's a care pathway. C for confirm that patient has got COVID-19, and A for assess the symptoms, risks, and severity. That's what we have to do: mild, moderate, and severe. Respond. Our response is give them oral antivirals or just monitor them and evaluate the response, whether they have any disease progression, whether they have responded to the oral treatment. So the provisional approvals by TGA. So TGA actually approved Avashield. I'll talk about Avashield. Avashield is the intramuscular injection. It's a combination monoclonal antibody. Sorry, a bit noisy. So it's a combination monoclonal antibody used as a pre-exposure prophylaxis for high-risk population. I'll talk about that. So in simple way, that's what we are following. So first, verify that they have a diagnosis of COVID-19. They're going to be having more than 1 symptoms, not requiring hospitalization at this time. They present to you within 5 days of symptom onset. Now, that's how you put them in the risk category. More than 65, high risk. This is for Aboriginal population, the blue boxes. If they are more than 50, they automatically come in the high risk population. Now, for an immunocompromised, anyone who is more than 18 is an immunocompromised, they come in the high risk population. So these are the groups you have to think about giving them the medication. So this is what we use, preemptive COVID-19 therapy flowchart. So every patient, if we decide to treat the patients for preemptive COVID, with preemptive COVID therapy, we have to give them inhaled budesonide along with the oral antivirals. So why inhaled budesonide? Because it's just inhaled corticosteroid, which will help with the inflammation. Why budesonide? Because most of the studies have been done on budesonide. If they are on any other inhaled corticosteroid for the asthma, you can just increase the dose of that inhaled corticosteroid. You don't have to add on extra budesonide onto their treatment. So we have Paxlovid, and first line is Paxlovid, and then second line is molnupiravir, because they are both oral. But if you think patient is high risk, immunocompromised, renal transplant patient, and they can't, renal transplant patients are usually on cyclosporines and other medications, and Paxlovid doesn't go very well with that. It's got a lot of contraindications and interactions. So these patients I would probably refer for IV remdesivir. So talking a little bit about medications. So Paxlovid is a combination of two antivirals, nirmatrelvir and ritonavir. They basically, it's a protease inhibitor which breaks the cycle of viral replication. And ritonavir is just add-on therapy. It doesn't do anything to the virus. It just increases the nirmatrelvir plasma levels. So, and ritonavir, issue with ritonavir is it's a cytochrome P304 inhibitor, and it interacts with a lot of medications. I've got a little list of medications. We'll go through that. So where did this data came from? Paxlovid. So all the studies for oral antivirals were done for Delta strain. So we still don't have a substantial study that will say, yes, this is the data for Omicron. So that's all in progress happening. But whatever we studied in Delta, because there is still some similarity, correlation between different strains, that's why we think that this is still working. And it has been proven that oral antivirals are working in Omicron group as well. So this, the study was called EPIC-HR. And only thing that I want, this was done in non-hospitalized patients. So they divided Paxlovid and placebo group, and 98% of the patients at that time had Delta. So just wanted to emphasize the study was done in the Delta population. And on this slide, I just want to show you, it is just the primary endpoint, which was the COVID-19 related hospitalization. So in Paxlovid group, you can see only 8 out of 1,000 people had it. And in placebo, 66 out of around 1,000 people had it. So Paxlovid has shown that there is 88% relative risk reduction for primary endpoint, which is the hospitalization in people who have got COVID. So this is actually very big and effective number to see, yes, there is 88% relative risk reduction. So now, how do we prescribe it? So that's how Paxlovid comes. It comes in pack. So it's got nirmatrelvir. So it comes in daily dosage packets, and one in the morning, one in the evening. So nirmatrelvir comes in 150 milligram. So nirmatrelvir, we have to give 115 to 2, 300 in the morning, 300 at night. And ritonavir comes in 100 milligrams in the morning, 100 milligrams at night. And we have to renally adjust the dose if someone has got renal impairment. So EGFR more than 60, you can go with the full dose. EGFR 30 to 60, you have to reduce from 2 doses of nirmatrelvir to 1 tablet of nirmatrelvir twice a day. So, but EGFR is less than 30, Paxlovid is kindly contraindicated. So then we go to the other line of treatment. And then you might have to call us to organize remdesivir for this patient, because remdesivir is IV, which cannot be done in the community. And that's where you call COVID at home team, and they will facilitate that for you and your patients. So now I'm still talking about Paxlovid. So if someone's got mild hepatic impairment, don't worry about it. You can give it. Child puke, C cirrhosis, severe hepatic impairment, Paxlovid is not indicated. So pregnancy and lactation, Paxlovid's out. All your oral antivirals at this point of time, Paxlovid, molnupiravir, pregnancy, lactation, breastfeeding, out. There is some, I'll give you some clues how to use it around breastfeeding. So we don't have for Paxlovid, we don't have data for less than 12-year-old, but anyone who is more than 12 years old and more than 40 kilos, Paxlovid can be used. But I would say if you have like a 13-year-old kid who is a cardiac transplant, pass it by your pediatrics team, because I had a lot of phone calls regarding these 13-year-old kid heavily immunocompromised. in those patients, we would ideally, discuss with their team in Sydney and give them IV remdesivir, other medications. So if you think someone is high risk, heavily immunocompromised, just pick up the phone, ask the team. For kids, because I did not have a lot of interaction with kids. I was dealing with adult medicine, but when I talked to all the pediatricians in the hospital regarding these phone calls, they were calling Sydney, St. Vincent's all the time, mostly all transplant kids, because they are special. We just have to make sure whatever we do is right, because dosing is very, very important. Whatever we do, they have these people, the dose is per kilogram, so dose needs to be calculated accurately. So limitations. So Paxlovid, we have to give it only within 5 days, and it's not recommended for severe or critical COVID disease. Paxlovid is not used for pre-exposure or post-exposure prophylaxis. If someone's Paxlovid is used just to avoid the progression of disease to pneumonitis. Now, drug interactions, as I said, cytochrome P3F4 inhibitor. So I'll show you the link. So this is a beautiful link. I use this link a lot. So it's COVID-19 druginteractions.org. So I've got it open here. I might show you now. I'll probably show you at the end of my presentation. So COVID-19 drug interaction website, it will take you to the Liverpool hospital website, and it will give you interaction checker. And there you can check all the interactions very easily. It actually gives you a flow chart and plan. For example, you have amlodipine, you want to start Paxlovid on amlodipine. It just increases the effect of amlodipine. You can just cut down amlodipine, keep an eye on the blood pressure. If someone's on NOAC and Paxlovid, then you say, they can't go together. So you have to get rid of, you can't give Paxlovid in that scenario. Some statin is very common drug. Stop statin for like 8 days, give Paxlovid to the patient. So this website, I highly recommend all of you use this, play with this one. This will be very, very helpful. Contraindications of Paxlovid, a lot of drugs, mainly all the antiarrhythmic drugs, antipsychotic drugs, drugs for pulmonary hypertension, anticonvulsants. So these are the population group that you got to be careful. Yes, Paxlovid cannot be used. Now, Paxlovid was approved on PBS on 1st of May, and 88% relative risk reduction with the EPIC-HR trial. But we have to be very careful with drug interactions, renal adjustment of the doses. It's not recommended in pregnancy. It's not recommended in severe hepatic failure. Now, these are the authority codes. When you go to PBS, so you have 3 authority codes for Paxlovid. 12923 is for patients who are more than 65 or who are at high risk. I'll give you the definition of high risk people as well in my next slide. 12839 is your code for patients who are immunocompromised, and 12936 is the code for Aboriginal population who are more than 50-year-olds and have got risk factors. This is how PBS looks. All of you might have used it. Sorry, I'm just verbalizing that again. So risk factors. So this is the population, defining high-risk population. That's where you think, yes, this patient would need antiviral. So the criteria is they got to have at least 2 of the following risk factors. So the population, first criteria was more than 65. So if they're more than 65, they're going to have 2 of these conditions. 1, they have a suboptimal vaccination. If they are more than 75, they automatically get 1 extra point. They are from residential aged care or disability care. They have neurological conditions, including stroke, dementia, Parkinson's. They have chronic respiratory diseases. They have congestive cardiac failure, BMI more than 30, type 2 diabetes. They have renal failure with eGFR less than 60. They have liver cirrhosis, and they come from remote areas. So we just need to have 2 of these factors in more than 65 population, and they will fulfill the criteria, the PBS criteria for Paxlovid. Signs and symptoms we've talked about this. Now, the definition of immunocompromised population. Which population is immunocompromised? So any primary or acquired immunodeficiency, including hematological malignancies, leukemias, lymphomas, myelodysplastic syndromes, all solid organ transplant people. Then you have anyone who's on chemotherapy or radiotherapy, anyone who's been on high dose steroids, prednisolone more than 20 milligrams for more than 2 weeks, someone who had pulsed corticosteroid in the last 3 months period, and people who are on biologics. So this is the list that I have been using for last couple of months. Other drugs, including mycophenolate, methotrexate, leflunomide, azathioprine. So all your rheumatoid arthritis population comes on card as well. So it's a big spectrum. So PBS has given us liberty to use antiviral in a big population lot. So anyone who is not well, anyone who is immunocompromised will actually find a code for that population to have oral antivirals. So I think they have covered it quite well. So main problem here is the population that was in hospital. So I'll share my experience with you. The population at highest risk is population who have leukemias and lymphomas, and they're on anti-CD20 therapy. So anti-CD20 therapy is just going to kill all your immunity. That's going to fight COVID. And these are the people who are having refractory COVID. Now, to you, I'm talking about COVID, but in hospital, we have refractory COVID patients who have COVID for 2 months, 2.5 months, and we're dealing with them, and we're trying to get more and more evidence from all the literature around the world, how we can treat this population. And in like maybe next 3-4 months, all of you will see these refractory COVID patients. And how do we check? We check their PCR is still positive after 2 months. We check cycle threshold value. So that tells us what's the viral load in the body. And they're still carrying a lot of very huge amount of viral load after 2.5 months. Molnupiravir, that's another oral antiviral. So it just incorporates into the viral RNA and doesn't let it replicate. So the dose for molnupiravir, it comes in 200 milligram. So we have to give 4 tablets for 5 days. And it's uncertain when EGFR is less than 30, but we have done literature. We have gone through all the patients. So we don't have to worry about renal functions for molnupiravir. We can still use it. So the molnupiravir trial was this move out trial. So it's still was running phase 2-3 randomized placebo-controlled double-blind trial. And again, this was also done in non-hospitalized patients with COVID-19. So in this one, the relative risk reduction was only 30%. Again, there have been no head-to-head trials between molnupiravir and Paxlovid. So I can't say which one is good, which one's not. They were done in different population, different countries, but both of them were done on Delta. But if we look at the number, the relative risk reduction for molnupiravir was only 30%. That's why, personally, if I have a renal transplant patient, I don't want molnupiravir. Paxlovid does not work. Then we go to remdesivir for renal transplant patients, because they had a huge bulk of renal transplant patients, lung transplant patients, cardiac transplant patients coming to hospital. I don't want them to compromise. I don't want them to have pneumonitis. Otherwise, their outcome's going to be very guarded. So we have to be very mindful. What population are we dealing with? Whether we have any better options for these population. So molnupiravir, as I said, 4 capsule BD for 5 days, can be taken with or without food. Contraindications: pregnancy out. So with birth control, so they say 4 days after stopping, if there is a possibility of getting pregnant. So no, they have to use contraceptions. For males, I actually looked it up a few times. For males, they say they have to use contraception for 3 months after they have used molnupiravir. So, your male patients might ask you for how long they have to use the contraception for 3 months after that. Breastfeeding, molnupiravir is not recommended. No drug interaction. So molnupiravir is quite safe. Where you have elderly population, they're okay. They don't have symptoms. Paxlovid is contraindicated because they're on so many medications. They are in nursing home. They're okay. Just give them molnupiravir, and that's the safest. And I think that's what you all have been doing in the community. Limitations of molnupiravir is, again, it's not recommended less than 18. You might remember Paxlovid, we could give after 12-year-old, but molnupiravir study has been done more than 18-year-old. So again, it can be used regardless of the COVID-19 status, no drug interactions. That's how it looks on PBS. So these are the codes for molnupiravir. Same thing as Paxlovid, just the codes are different. So patient who got more than two or more than 2 risk factors, and who are more than 65, 12923, and population who are immunocompromised, 12839, and Aboriginal population who are more than 50 with 2 risk factors, 12936. So same thing, risk factors, we've already gone through these. Same apply for Paxlovid and molnupiravir. Signs and symptoms are the same. Immunocompromised patient definition is also the same. I think at primary health care practitioner level, the living guidelines in Australia say you have to keep record of everything. So it can't be a word of mouth that this patient had PCR or rat positive. It has to be documented. If PCR, you have to keep a record. If it's the rat, then one other nurse or other staff have to cite it as well to make sure that this patient has COVID so that you get approval of the medication. So when rat is used to confirm the diagnosis, the test must be verified by a medical practitioner or nurse practitioner. So someone's got to be making sure. We just can't take it from the patient. Patient says, I had rat positive, give me molnupiravir. That's not done. They have to either show it to you or we have to do another rat test when they present to your clinic. It's if they show it to you on the video chat, yes. Or you access the lab and they do the PCR in the lab, and then you can check the result and then you can give it. So I'm just telling you, I actually looked it up yesterday and I said, this is actually on the living guidelines of Australian Health Force that someone has to cite it. You know, people are not selling molnupiravir or Paxlovid in the community like Endone and Oxycodone, but we have to prove it that this patient's actually got COVID. You know, because no medication is without side effects. We have to make sure, yes, this patient is time up. Okay. Time up. All right. We've gone through this. So inhaled budesonide, very quickly. So the drugs that are out of market are because these drugs basically were meant for Delta and we're not using them out. So sotrovimab is out and Ronapreve is out as well. So Ronapreve was the combination, and again monoclonal antibody, casirivimab plus imdivimab, that's out, because if you don't have anything else, that's not the case in Canberra. We do have everything, so we don't have to go to this. So if you don't have anything else in remote community, you just have this drug, use it, but this is not the first line and this is not meant for Omicron. Omicron is the primary variant now. So Trovimab, same thing, we can't use it. Quickly, Evusheld. So Evusheld is the new drug in the market. It has been approved in USA on emergency basis. This is meant for pre-exposure prophylaxis. All immunocompromised people who could not have vaccination because of some reason, and because of the immunodeficiency status, they could not mount the response against the with the COVID vaccine. That's the population who approved for Evusheld. So more than it's approved for more than 12 and 40. It's not on PBS, so it has to pass through Drug and Therapeutics Committee in the hospital. I think Chloe might talk about that, but that's what I've been doing in the hospital. So I have to do the separate applications for these Evusheld, and I've been giving this to refractory patients as well. Like I'm running out of everything, then just use this big gun and give this to the patient. In next coming months, we'll have more information about this, but we are giving it to all immunocompromised hematological patients who either can't have vaccination or with vaccination, they didn't have the response. So 2 weeks ago, we gave around 150 doses. And this was proven on the Provent New England Journal of Medicine trial. My time's up. But at the end of it, I'll, if you guys have more answers, more questions, I'll answer them. So the base is we have to take protective measures. In last week, the number has gone up significantly in ACT. Today it was 1400 something. So everyone's gonna, again, I shouldn't say that, but we have to take a lot of precautions for COVID. It's coming back. So another wave is coming. Thank you very much for your attention. So I just want everyone to have a quick look at this one. So if you just type COVID-19, it's covid19evidence.net.au. That's where you have all the living guidelines. So you have information about all the drugs that you want to know, and you have all the clinical flow charts as well. I did not talk about pregnant people, kids, adolescents, but if you go through this flow chart, that will give you all the information. And this is the website I was talking about, COVID-19. Just type COVID-19 drug interactions. That will take you to this page. Then you go to interaction checker. click on interaction checker, and then it will give you 2 columns. So we are checking, so Paxlovid doesn't come up, but you just type nirmatrelvir, it comes up. And for example, I'm just typing, say, atorvastatin. Okay, so I've typed atorvastatin. Fine. So I think it's in the GP talk, but you get everything on this, and it tells you what to do with your drug. And
our next speakers are from the COVID-19 Care at Home team. We've got Tomika Gnech and Dr. Anita Hutchison. Tomika is a long-standing dedicated nurse in the ACT for over 25 years. Tomika has worked in various departments across emergency, ICU, hospital in the home, and palliative care. Currently, she is one of the nurse team leaders at COVID Care at Home, providing tailored support and monitoring to COVID-positive patients in community via telehealth. Dr. Anita Hutchison is a general practitioner, mum of 3 dogs and 3 children. Anita loves being a GP with special interests in antenatal care, pediatrics, and mental health, and keeping current with anything COVID. She enjoys walking and singing in her not-so-spare time. So they're going to go through some cases today of real patients, which is what GPs love to see. So please welcome Tomika and Anita.
Thank you to Alex, and thank you for all of you for coming this evening. We appreciate that you've been working like crazy people all day, all year really, and for taking the time out this evening. Okay, we thought it might be helpful just to go through a bit of what the background is to our program. So the COVID Care program was launched in 2021 in August during the memorable Canberra lockdown. It was a program that started 7 days a week, and we continue with that. Office hours were 8 to 6 then in the initial days, and then a staff member would take the phone home and they'd be on call all night. Medical and nursing staff are recruited within the facility, so within Canberra Health Services, and they were drawn largely from outpatient areas, including sexual health, the respiratory clinic, the chronic care program. In August last year, every single COVID positive case was contacted on receipt of their positive PCR test, and they were monitored daily, if not daily, every few days. And within that monitoring, they would receive a risk assessment where their symptoms would be triaged. We would look at the feasibility and the benefits of providing them with equipment, oximetry, a thermometer if they didn't have it. And once treatments became available, their eligibility for it. In October 2021, our service then became a true 24-hour service in the sense that we had then community nursing take over from us from 6 p.m. until 8 a.m. So December last year, we went from paper-based documentation to the digital health program Epic. And this also then became a new avenue for self-reporting for all COVID cases via this digital health record through an app called the MyChart app. Between November and January this year, all those lovely staff that we'd stolen, the outpatient areas, were returned to their spaces, and 10 FTE, roughly, nurses were placed on a temporary contract into COVID Care at Home, and 1.2 FTE GPs, and this remains our current staffing. In this time period, as you all well know, COVID cases markedly increased, particularly around the December period, and we were no longer able to meet that daily, every few days contact. So we had to scale down what was manageable, and that then we from then on focused on priority groups. And these priority groups are those that Dr. Aurora mentioned: people with comorbidities, people immunosuppressed. February, March this year, we were delivered the National Medical Stockpile of Molnupiravir initially, and then Paxlovid. And as you well know, you're on board now. It's a bit of a tricky thing, but we're managing. March, April, sotrovimab, the monoclonal antibody, which we've been offering to certain population groups from August last year, was removed from treatment due to limited efficacy, as Dr. Aurora mentioned, because of its limited efficacy against the BA2 variant. So what is this notification process? How does it all work? So there's a few ways that the consumer information reaches us. It comes from patients, carers, friends. Anybody that has received a test in that little cohort, they're able to call us, leave a message if we don't get to them on time. Public health, the pathology labs send the notifications directly to public health. Now, today, we've got the rapid antigen home test. When people register, that data also gets sent to public health. Once all that data has been collated, messages are sent out to each consumer, and depending on what they've self-reported, they will also get a text saying, please notify your GP of your positive PCR rapid test or contact COVID care at home. We also get referrals from lovely people like yourselves, and please keep them coming. We're very happy for you to call, it doesn't matter about what, and internal and external specialists within the health services. We also do get, not as frequently as I would have thought, but ED medical officers also wanting to send people home, perhaps needing some guidance with treatment options, but also wanting us to follow up with them. Thought it might be helpful just to let you know what our assessment process is. So the initial assessment is all the basics. We confirm that it is that individual, that are they of Aboriginal and Torres Strait Islander background? How is their English? We do come across a lot of people like yourselves who have difficulties with the English language. So establishing that early. So should we need to use an interpreter service, we sort of hold things there, arrange the interpreting and then move on. We look at what date they returned a positive test, whether it was PCR, rapid test, what day their symptoms started. Oh, thank you, the vaccine, very important. We do like to know how many vaccines individuals have had, and it can be quite variable, as you know, depending on whether they're immune suppressed according to the targeted guidelines. The health questions that we ask, their height and weight to establish the BMIs. We know obesity is a significant risk factor in conjunction with other comorbidities. We look at high-risk features, which Dr. Aurora went through. I won't go through them again. Past medical history. So we're very, very reliant on the individual carer, friend, to let us know things as accurately as they can. And at times this hasn't been as successful as we'd hope it would be. We have very limited information we can access. Obviously, if somebody's been in hospital, we can look at previous records, but many people haven't frequented the acute facilities for some time. Current medications, allergies, and also high-risk social factors, social isolation, low digital and health literacy. So we just note that, and if we're able to, facilitate some support in other ways, we do that as well. All right, symptoms, important one. The symptoms that are listed there are the ones that have been predominantly reported since August last year. Omicron's delivered a few little extras, but primarily they seem to still be the ones that people most report. Drinking, eating, going to the toilet. It's something we discuss every day when we touch base with people, reminding people that they're simple health management strategies and just to keep on top of those. We also ask, has the patient also had to attend the ED or the hospital for any form of treatment? Is there any other family members positive within the household? We then assign them a risk category, and in our program, most people have fallen within the low moderate category. If anyone's ventured towards the moderate high, which often means they've got significant work of breathing, maybe requiring oxygen, they tend to be hospitalisations. And early in the piece, when we were calling consumers daily, we would re-stratify them each day depending on their progress. So we've now completed the risk assessment, and from there, if I have some concerns and one of our lovely GPs is in on that day, I will, refer the consumer to them, for a bit of a review. And also, we've also been fortunate enough to be able to get your support as well. And as far as equipment goes, we've routinely, we were giving out equipment quite a bit early in the piece, but as time's going on with, significant case numbers, that's not something we're routinely doing. But by all means, if you have had contact with one of your patients and you're concerned for them, I have had a few people call and say, look, my GP would like me to have an oximeter. Please don't hesitate to let us know, because you would be asking for a specific reason. So please let us know. We provide our COVID care number. Our service is now only 8 to 6, so it's been scaled back. We don't have the overnight contact service anymore, so we ask that the consumer call the National Hotline Health Direct between 6 p.m. and 8 a.m. So what's important? I'll hand that over to Anita.
Hello. So this is where I come in, but I guess now it's where everyone else comes in as well. So what is important? So maybe I can get from the audience actually what you think is important when you take a call from someone in general practice. I know your mouths are full of food, but any takers? Yes, well done. Anything else? Oh, okay, reiterate.
So when they first had symptoms and when they first tested positive. Yeah, I'll pass it on to someone else now.
So symptoms are the most important thing, but it is nice to know what means of tests they've undertaken. And I've just clicked on one, sorry. So age of the patient's important, obviously for PBS criteria, but also because of risk, as we've just discovered with Dr. Aurora. Anything else you want to know about your patient if you don't have a good file in front of you? But, yep, that's definitely something down the list, because now, as we know, with the PBS, it's they're eligible regardless of vaccination, but certainly puts them in a higher risk if they're not immunised. Anything else? Anyone? What was that? Yay! Medical history, comorbidities. If they're immunosuppressed, that's super, super important, as we've discovered. They're vaccinated and they're comorbidities. All right, what else do we need to know? Just the other stuff. We don't want any nasty drug interactions that we're not expecting, so we want to know what sort of other over-the-counter medications or drugs they're taking. We really want to know their renal function if we're going to prescribe Paxlovid. And of course, their symptoms, because what can we do about their symptoms? Lots and lots of things. So in terms of symptoms, what would you do if a patient came to you on telehealth? What sort of things would you assess, and what would be your next steps in terms of if you're concerned that they need a face-to-face? So any takers on symptoms? Yeah, breathing. So shortness of breath, tightness of chest. If they've got an oximeter or a thermometer at home to record their observations, to let us know how they are when they're actually getting out of bed and walking around, if they're able to actually breathe. What's their level of concern as well? And also, as we went through previously, their urinary output and input. So if you're worried, what do you do when you think your patient does need a face-to-face, but you don't necessarily need to call the ambulance yourself? What do you do? So we've got a couple of options. We've got the Crace Respiratory Clinic, we have the Garran Walk-in Clinic, and of course the emergency department. Okay. So we've actually already seen the eligibility criteria for Paxlovid and molnupiravir. So I probably won't labour that too much. Drug interactions are a must to check if we're going to consider Paxlovid. If their eGFR is less than 30, you'd probably opt for molnupiravir. If, of course, they haven't received a transplant of some description where they may require remdesivir. And if it's Paxlovid, you dose adjust depending on their eGFR. I did want to show you actually how to use the drug checker, but it's already been shown. I guess I just wanted to pick out a couple of ones that were really big no-nos in terms of drug interactions. That's tacrolimus for people on therapy for organ transplants. Colchicine is another one that is a little bit unpredictable in terms of how the drug is taken up in the tissues, and it may sit there for weeks and weeks. So even if they say, I took colchicine weeks ago, it's still not safe to give Paxlovid. And don't give Paxlovid to anyone with eGFR less than 30. But if you're worried and you've got a drug that you can't find on the drug checker, just call us on that number. That's our GP mobile number. That's the sneaky number. So, case 1. Oh, okay, I'll go back. Sorry. It kind of rolls off the tongue, this number, 0422226264. Anyway, I'll carry on. So case 1, I thought I'd demonstrate some immunosuppression here. This person's obviously been adequately vaccinated, and they're on a B cell depleting agent, ocrelizumab or Ocrevus. They're on this for MS. They've also got a couple of other risk factors here, such as asthma and their BMI. Okay, so I've been really kind on this slide, and I've asterisked the drug interaction, which on the whole, a lot of these drug interactions are mild, and probably you could stop those medications or just reduce the dose, as Dr. Aurora said. There's only a couple of really big no-nos, but they come up red on the drug checker. Okay, so this particular person had a couple of things going on. They had adequate contraception on board, and the eGFR was lovely. In terms of what we do, I guess at COVID Care at Home, and what we had been doing is chasing lots of history from these people if they weren't great historians, and always chasing eGFRs. So in some respects, you are better placed than us in finding those little eGFRs that are sitting in your file from recent bloods from their specialists. Okay, you can't really see it probably very well at all, but and I certainly can't, goodness me. I think it was just the amitriptyline. And I think I even said to the patient, you can reduce the dose if you want, or you could stop it. We say stop it for 8 days because it's the 5 days of the treatment for Paxlovid and the 3 days to wash out. And we generally use that rule of thumb for most of the medications that you choose to withhold. Okay, so there's that. So it's 2 of the Nematrelvir, 1 of the Ritonavir, twice a day for 5 days, 30 tablets.
So just as far as monitoring, so Anita's reviewed this consumer, we've organised the medication, we give them a call the following day. These are just the things we check in with. It's quite brief. Just talk about if they started treatment, we document what it is, discuss any symptoms, particularly symptoms of concern, eating, drinking, drink. The biggest focus is probably on the hydration. And again, if people do have capacity to monitor things, we just record their temperature, their oxygenation, and if they've required any further review, particularly in the ED, or had to go to hospital, and then we re-stratify them again.
So this is my second case, which is a gentleman who identifies as Aboriginal. He's appropriately vaccinated. What are his comorbidities with PBS here? True. With the PBS, yes, exactly. It would be definitely type 2 diabetes and the BMI. So he does qualify for some oral antiviral medication. Okay, he's on a couple of different meds, which is the one, oh yeah, I've asterisked it, there I go. Whoops. It's a simvastatin that comes up red on the Liverpool interaction drug checker. So you could just choose to withhold that for the 8 days. So what is the difference between Paxlovid and molnupiravir? So this is probably a slide that I've stolen from the US. And some of the points on it don't apply to us at all in Australia. In terms of efficacy, Paxlovid probably reduces disease progression by about 90% compared to 30 with molnupiravir. But obviously molnupiravir comes into its own when we can't use Paxlovid. And obviously when we have an eGFR of less than 30. So try and use Paxlovid as much as you can. I know it's a bit trickier, but like I said before, if you have any problems, just contact us, especially in a high-risk person who's immunosuppressed. I would really try and prescribe Paxlovid. So what do we do next with this gentleman? We've checked his drug interactions. What else do we need to check if we're going to prescribe Paxlovid? eGFR. So his eGFR was fine, greater than 90. I discussed just withholding his simvastatin for the 8 days. He was on a combination. He was really keen for Paxlovid, so we went ahead. Another case. So I'm trying to choose cases that tick those numbers on the PBS. This is over 65 with 2 risk factors. Appropriately vaccinated. He had a few things going on. What are his risk factors? What are the obvious ones? So obviously the type 2 diabetes, if he was on medication, and the marginal zone lymphoma, which is a hematological malignancy. So here is medications. I was mean this time, and I decided to see if anyone's a bit more across these drug interactions, and can you yell out the most obvious one that you would go, no Paxlovid. Yay, well done. So unfortunately this man, because he's had a PE, and I think it was a recent PE actually, we could not stop his rivaroxaban, and I probably wouldn't anyway most of the time. But he's obviously, the other drug interactions were atorvastatin, amlodipine. It's a mild one. He was also on an opiate, and with opiates you get more bang for your buck. So in terms of the Targin, if you really wanted to and you needed to stay on it, you would just reduce the dose and watch for respiratory depression. Yes.
There was some talk hospital where we switched with Roxaban to Paxlovid therapy.
You can.
Or
You can swap rivaroxaban for Clexane. That's true. I was trying to make it a bit easier because I've even had a case where I reduced the dose of warfarin in somebody and we continued. So, but I did have that in the talk, but we decided it was a bit too complicated. So they're the drug interactions that we just discussed that you can find on the checker, and then you can download the PDF for the summary, and it's all there. So our plan was to go, look, it's a molnupiravir day for this particular person. So 4 tablets twice a day for 5 days. We always discuss side effects, and mostly the gastrointestinal with molnupiravir. With Paxlovid, they tend to be that metallic taste in the mouth gets everyone every time. This is one of my last cases, I believe. So an older person with 1 risk factor, 88-year-old, vaccinated. What are the risk factors here? And how many, but we only need 1, but what are the risk factors here? So we've got renal impairment and we've got asthma. She also had mild rheumatoid arthritis and was on some medication, but not a medication that is immunosuppressive in that sense. It has an anti-inflammatory effect, Plaquenil. So what do you do next? Remember, do you drug interactions? What's the second step if you want to consider Paxlovid? Renal function. Drug interactions were negligible in this case. You could stop your Plaquenil, but you could continue it. It's a risk-benefit thing. It's on the PBS. Yeah. If you drop down on the actual PBS, it's there. But if you want, we can send it out. Yeah. Okay, so her eGFR was reduced, as we'll go back and see, it was 53. So it was between 30 and 60. So we had to reduce the dose of the Paxlovid, which is 150 of nirmatrelvir and 100 of ritonavir. So only 2 tablets twice a day for 5 days. Some special weird ass cases. Oops, I swore. They're the ones that Dr. Aurora was talking about as well, that they don't fit into PBS criteria, you might be worried about them. There's a complex medical history, or they're pregnant. So we can take from the National Medical Stockpile. We have limited supply, but we do consider special cases, especially where the treating team outside the general practice community. So they're specialists if they're under a rheumatologist, immunologist, hematologist. We would consider taking from the medical stockpile if they're concerned. Anyone unvaccinated, it's not on the PBS, especially if they're younger and they don't meet that cutoff, either Aboriginal and Torres Strait Islander 50 age group or the other age group for over 65s. If they don't meet that cutoff, this is a really good sort of quick example of us deciding to dispense from the medical stockpile. This poor man had quite a few risk factors. So an unvaccinated pregnant person, which I have come across quite a few times, with at least one risk factor, we tend to consider remdesivir and discuss that with, usually discuss that with obstetrics and FMU before going ahead with it. It's a 3-day, it was a 3-day inpatient delivery of remdesivir. It's changing slightly in terms of how we deliver that. And the last slide is how are we going with our prescribing in the ACT? And certainly, obviously, early in the piece, there wasn't as much PBS prescribing at all. This is PBS and RPBS. It was mostly done by ourselves, a very small team at COVID Care at Home. And then molnupiravir started to come onto the PBS, etc. And as you can see, we're going really well in terms of community prescribing. And as time goes on, that number of Paxlovid will actually come up with more confidence in prescribing and knowing what we have to do, drug interactions, eGFR. And take home message, alone we can do so little, together we can do so much. Thank you.
Thank you.
Our next speaker is Chloe Langfield. She's a community pharmacist at Coolman Court Pharmacy in Weston. Her team was recently awarded Australian Pharmacy of the Year for 2022. Chloe has worked on the ground during the pandemic, and her team have administered over 16,000 COVID vaccinations, supplied over 20,000 rats, and more than 100 doses of COVID antiviral medications.
Thank you. I'd like to begin by acknowledging the traditional custodians of the land on which we meet today, the Ngunnawal people, and pay my respects to their elders past and present. I recognise Aboriginal and Torres Strait Islanders people's vast knowledge of native plants and their uses, as they were our first pharmacists. I acknowledge this important connection to country and appreciate the stories, traditions and living cultures of Aboriginal and Torres Strait Islander peoples. I'd like to extend my respect to those present today. Thank you for inviting me to speak today. My name's Chloe. I'm a community pharmacist at Coolman Court Pharmacy in Weston. We're part of the Life Pharmacy Group, which has numerous stores in rural New South Wales, in addition to the 3 stores in South Canberra, which are Lanyon, Erindale and Coolman Court. I'm very proud to have worked for the Community Pharmacy announced as 2022 Australian Pharmacy of the Year. Life Pharmacy Group have been heavily involved with the COVID-19 vaccination rollout, provision of rapid antigen tests and supply of COVID-19 antiviral treatments. Our 10 stores have administered over 50,000 vaccinations, provided over 300,000 rapid antigen tests, and about 100 or so courses of antiviral treatment. At this point, it feels like I've probably done about 10,000 vaccinations myself, but it's been a pleasure to support the Canberra community throughout the pandemic. We pride ourselves on collaborating with other healthcare professionals to improve the health of our patients and look forward to continue doing so with this expansion of COVID-19 antiviral prescribing. As I'm sure you're well aware from the previous presenters, community pharmacy has access to 2 antiviral treatments for COVID-19, which are Paxlovid, which has been affectionately named Pavlova by our dispensary team, and Lagevrio, fun name still pending for that one, but we'll take suggestions. Pharmacies can order these through 4 main wholesalers, which are Symbion, Sigma, API, and CH2. In Canberra, this is generally associated with a minimum 24 to 48-hour delivery turnaround from the wholesaler. This depends on the pharmacy's usual ordering procedures and timing of the order, noting weekends and public holidays, as well as some recent stock shortages. These antiviral drugs are also high cost lines, with their wholesale cost being about $1,000 per box. As such, you may find that some pharmacies aren't keeping the drugs on hand readily, instead only ordering when they're presented with a prescription and thus guaranteed claim of the cost on the PBS. The 3 Life Pharmacy stores in ACT, Coolum Court, Lanyon and Erindale are stockists of both Paxlovid and Lagevrio, and thus we generally always have supply for your patients. Noting the narrow window for starting antiviral treatment and often lengthy wholesaler delivery times, this represents a barrier to treatment if stock's not readily available at your local pharmacy. If you're seeing this in your practice or you work closely with a community pharmacy who's not stocking the treatments, it's worth noting that there's currently some wholesaler return initiatives. So some wholesalers are offering pharmacies credit on Lagevrio and Paxlovid lines if they're not sold before they pass their expiry date. I'd encourage you to communicate with your local community pharmacy your intent to begin prescribing COVID-19 antivirals after this evening, and request that they keep them on hand for your patients. So how do you find a pharmacy who's stocking Lagevrio or Paxlovid? It's quite easy. You just head to this great and very intuitively named website called findapharmacy.com.au. The search function allows you to input the patient's postcode, and you can view a list of pharmacies who stock Lagevrio and Paxlovid, as well as offer a delivery service. It also displays their opening hours and contact details. So you found a pharmacy who stocks COVID-19 antivirals. Let's talk about how you get the script to them. There are a few different ways, and unfortunately, like most things in healthcare, they all come with some sort of administrative burden. First up is Escript Tokens. They're a bit of a polarizing topic for most patients. A lot of people love them and a lot of people don't. They're convenient. They can be sent straight to the patient's email or mobile phone, and this is beneficial if you're doing telehealth consultations. Tokens can unfortunately be confusing for many of our elderly patients, and noting that this is the primary demographic for which you'll be prescribing antiviral treatments. Many elderly patients don't have a phone with internet capabilities, or they're unable to locate the token amongst pictures of their grandchildren and spam text messages and all sorts of things. In patients who are isolating with COVID-19, the challenge lies in actually retrieving the Escript token from them once the prescriber has issued it. Scanning the token in store is not possible for these patients unless the token is forwarded onto the pharmacy or onto an agent who can present it to the pharmacy on their behalf. Alternatively, the doctor can send the token directly to the pharmacy email address, but the email contents unfortunately don't contain any identifying information about the patient or the medication. It's just a QR code. There is Active Script List, which allows us to view and access a consolidated list of the patient's electronic prescriptions without relying on the need to actually scan the token for dispensing. But legislation states that in order for a pharmacist to register a patient for Active Script List, we're required to cite photo identification and their Medicare card before obtaining their consent, which also proves difficult when a patient's in isolation. Next up is fax, old school, I know. While fax is the usual means for sending prescriptions, it's not particularly compatible with the telehealth model of prescribing, particularly if you're consulting from home or outside of your usual practice hours. It is much easier to convey notes and information via fax than it is via e-scripts, such as the patient contact details. Just noting that recent changes to legislation in the ACT now mean that all prescriptions that are sent by fax must be posted to the pharmacy within 7 days of prescribing, and unfortunately stamps aren't getting any cheaper. Another option you've got is phone order. Verbal prescription orders from the prescriber directly to the pharmacist are a sound way of getting the script details to us, particularly during telehealth consultations if you've got no access to prescribing software or a script pad. Just noting that a written prescription needs to be provided to the pharmacy within 24 hours. Some pharmacies might not prefer this option as it's less secure and there's no physical record of a script at the time of dispensing. Lastly is provision of the physical script to an agent. This may be an option for some patients who have family or friends that are able to collect the script from the surgery and present it to the pharmacy on their behalf. Most of the time you'll be utilising the previous 3 options though, unless they have really nice friends. Just in summary, e-scripts, they're easy to issue for telehealth consults, great if they're tech savvy and they're able to forward the token on to us. Also great if their preferred pharmacy doesn't have antivirals in stock so they can try elsewhere, but not so great for those with limited tech skills. Fax has lots of administrative burden, but it's easiest for us as pharmacists to access and then action accordingly. Phone order is an okay option. Probably save this for emergency situations where your prescribing software doesn't work. Provision to agent is also an okay option if they have nice friends, but ultimately utilise the option which ensures the patient will get timely access to the medication. Some helpful information to include for the pharmacy, either on the bottom of the script or by phoning us or sending us an email, is the patient contact details and their agent's contact details, your contact details, especially if it's outside of your surgery hours that you're prescribing, and the authority form number and streamline code. These are the 3 essential things. If you can, other helpful information is the patient's Medicare card and their concession card number, whether or not they require delivery or if an agent's going to collect on their behalf. The words renal adjusted dosage. We've sometimes been getting Paxlovid prescriptions that have inadvertent reduced dosages in patients that don't actually have reduced renal function. So it's helpful to know whether this has definitely been intended. And a list of the patient's medications and any management of drug interactions that you've discussed, if you have discussed it. Provided the patient meets the PBS criteria and the prescription has the authority form number and the streamline code, the cost of the medication to the patient is $42.50 for general patients and $6.80 for concession card holders. Patients who aren't eligible for PBS subsidised prescriptions and those who don't have a Medicare card will pay around $1,300 for a private Langfield or Paxlovid prescription. Just note that Australia does have some reciprocal healthcare agreements with some countries, so overseas visitors from these countries may be eligible for PBS subsidised even if they don't have a Medicare card, but they do need to provide the pharmacy with a copy of their passport to access that. And just noting that most pharmacies who offer a delivery service will only operate within their local catchment area, and they're likely to charge an additional delivery fee to the patient. So after we've wrangled the e-script token from the patient or got the script from the fax, the pharmacist will contact them to arrange for delivery or collection by an agent. We understand that when patients aren't well, they often don't take in a lot of information that's provided during their telehealth consultation. So during the conversation, we'll discuss the treatment prescribed, how they actually take the medication, what to expect and where to seek further assistance. We'll discuss with their patient their current medications and screen for any drug interactions using multiple resources. If we do identify any drug interactions, we'll contact the prescriber and discuss with you what the best course of action for the patient is. Noting that Langfield doesn't have any significant drug interactions, whereas Paxlovid has hundreds. I've listed some useful databases on the slide for your reference. Obviously, we've all been plugging the University of Liverpool website. It's a great resource. But just to reiterate, you just select the COVID-19 antiviral on the left-hand side. The middle column is selecting the patient's medication. And then the right-hand column will give you search results based on what actually interacts. It's sorted by the likelihood of the interaction occurring. If you actually click on the interaction, it'll give you information on how to proceed with treatment. Just noting that this is not an exhaustive reference, so not every medication is listed. So if you can't find something, there's a list of other references that are helpful as well. Before delivery to the patient, we'll ensure they understand how to correctly take their Langfield. We'll include both written and verbal instructions on the dosage, adverse effects, and what to expect with the treatment. For Paxlovid, the blister sheet can be a little bit confusing for some patients, particularly if they're taking the renal adjusted dosages. The blister itself actually specifies to take all 3 tablets at the same time, but they'll actually only be taking 1 nirmatrelvir tablet. We usually cross out 1 slot from each side to minimise any confusion. We also provide the patient with additional resources should they need further assistance while they're in isolation. These include our 24-hour pharmacist hotline if they have questions about their antiviral medications, the COVID-19 clinic at the Garran Surge Centre for patients to seek medical care should they need it while they're COVID positive. The COVID-19 pandemic has highlighted the importance of collaborative care in optimising health outcomes for our communities. The healthcare sector has faced unprecedented challenges in the last 2 years, and COVID-19 antiviral prescribing shouldn't be another. As pharmacists, we pride ourselves on being strong contributors to healthcare teams, and we're readily available to assist you when needed. I encourage you to form a relationship with your local pharmacist. We don't bite. We're always up for a chat, whether it be about drugs, therapeutics, or shared complaints of being a frontline worker during a global pandemic. Thank you.
Our last speaker is Dr. Anna Colwell. She is a GP who also works as a senior medical advisor in public health. She currently works in the COVID response team at ACT Health, helping with public health advice, support for high-risk settings, and communication with the public and health professionals. She's also a GP at Your GP at Denman and Your GP at Grace Respiratory Clinic.
Thank you. Now, I'm going to give you very little to no useful clinical information for the individual person, because in public health, there's not a real lot in terms of antivirals that we do that's got that clinical knowledge. But I'm going to try and give you the context in which we're prescribing antivirals in the ACT at the moment. So I'll kind of try and run you across that sort of bigger picture stuff at the moment, and probably bring a few other sorts of respiratory illnesses into it at the moment, because we know that COVID's not the only thing that's circulating and causing people a lot of grief right now. Let's make sure. So this is ACT Health's been working on winter preparedness stuff for a while, and it's very much been around respiratory illness. We know we were predicting that there was going to be possibly a little bit of a slide off of the Omicron wave after the beginning of January, and then have a pickup into winter, which is what we're starting to see. There's information now coming through that we talked a little bit earlier about the variants. The BA4 and 5 variants are starting to take off, and we're quite possibly going to see a bigger wave of that coming over the next months as well. We're expecting quite a decent flu season after not having seen influenza for 2 years. There's basically been virtually not a notification of flu over 2 years. And of course, all of the other respiratory illnesses that we see that you don't necessarily test for, you don't necessarily see but on a test, but it's definitely going around. So in terms of what public health is doing over that time, is we're doing the surveillance to look at what things are we seeing. We're trying to provide support for outbreaks in high risk settings such as residential aged care, disability residential settings, correctional facilities, things like that. And trying to look at public messaging and any other supports that we can provide to healthcare over that time. So first up, I'll give you some of the spot for the stats. For those of you who like stats, some of these are updated every day on the ACT Health website, particularly the ones under the red spot there. This is yesterday's numbers, not today's, because I had to fill them in this morning. You can see that there's sort of 6,230 active cases. Active cases are people who are within that 7 days from diagnosis. And that's starting to creep up a little bit, which is starting to tell us that it's starting to go from having been relatively stable over a number of weeks to starting to tick up again a little bit. You can also see 155,000 total cases, and that's since the start of the pandemic. That's around about half of the ACT population now. So you can go there anytime you want. In that same site, you can also see the weekly, more detailed data about epidemiology of COVID in the ACT. This is, again, from last week's one, which looks at kind of the pattern over the last 8 weeks. The one that we're seeing that should be out in the next day or so, again, is starting to have that little tip up at the end with the new cases coming through. Not going to talk. We're at the end of the night, so I'll try not to be too long with everything. So tapping into that antiviral, given that what we're here for tonight. Now, this is looking at PBS prescriptions dispensed in the ACT by different weeks. It doesn't include the National Medical Stockpile information, which was, the pre-placed stock in residential aged care facilities, the little bits that are being dispensed through care at home. But you can see that the numbers are actually still not that high in the ACT. And it's really tricky to know if that's just because people have been evaluated, decided not to be eligible, or for whatever reason, or if people haven't known to go and talk to their GP, or if their GP's seen them and gone, yeah, you don't fit, correctly or incorrectly. We just don't really know. So there are kind of other mechanisms we've moved on to, but I just was thinking earlier about the codes, and I just wanted to just stop and do a quick survey. Who in the room has actually prescribed Paxlovid or molnupiravir? All right, and how many of you are reasonably certain that you put the right code on it? You're all better than me, because I sat there and went, oh, I don't know if I put the right code on. Because that's also, sort of one little piece of information that we can kind of go, oh, well, if it was given to people in that age group, and we've had rising numbers in age group, but the Paxlovid's use is not rising, you can kind of use those little bits of correlation to see if it's being used enough or not, but it's tricky. I'll get onto what we're doing to try and raise awareness in a tech. But probably the reason why this starts to become important is we all know that there's a lot of stress on the hospital system at the moment. There's a lot of stress on us. When the hospital system is stressed, we all know that as GPs, we get the backlash from that, and all of the people, the extra people that we have to look after who perhaps would otherwise been in hospital a little bit longer or a little bit more easily and things like that. So when we have increasing case numbers at that population level, if we can prevent people going to hospital, that actually relieves the load on all of us. So that's where use of the antivirals kind of really where the rubber hits the road for all of us as individuals, as well as the population as a whole. So the things that we're trying to do in ACT Health is we've worked with a whole group of different people to put together this postcard that you all have seen earlier, which is given out to quite a lot of people who attend the ACT Health testing facilities for a PCR test. So that's one sort of captured audience where you can kind of go, look, if this does come back positive, you might need to get some antivirals. And so they'll get that little card and be able to kind of use that as a bit of a reference in the future. This is going out to pharmacists, have got a few. It's starting to go out to GPs and things as well, in case they want to stick it up. And the poster as well. That was a request when pharmacists saw the card. They went, can we have that as a poster so that we can start raising awareness in the pharmacies when people come in to pick up their chronic medications. Chronic disease medications, they can kind of go, oh, hang on, if I do get COVID, maybe I need to have that conversation with my doctor as well. And we've Care at Home team covered most of this, but again, looking at the patient journey is thinking, what are the possible times? So here, the gold stars are the situations where you can kind of flag with people, if you're positive, if you do get positive, you might need to have some sort of treatment which can decrease the severity of disease. So of course, there's that pre-illness stage of things. I know Anne-Marie has been really proactive about telling all of her people who might fit the criteria that if they get positive, then they're going to need to get the prescription straight away. There's probably others who have done that as well. But otherwise, you can have someone, then the blue flags I'll also mention, because they're the times where people are given messages from either ACT Health or COVID Care at Home to talk to their GP. So if someone has respiratory symptoms, they might see their GP or one of the other places. They might go get testing. They might do a RAT at home. Now, I just wanted to clarify, because we have gone back to the Commonwealth government about the whole, you have to see a RAT done in front of you for the person to be eligible. If they have registered their RAT and received a message from ACT Health, which is what they get, that is enough evidence to say they've got COVID, and they can be given an antiviral without doing a RAT that you have visibly seen. And that's been confirmed over a number of different times. It's been said at the government one. So just to clarify that as well. Yeah, so that's if a GP is seeing them, then there's a potential opportunity there as well to say, look, if this does come back positive, you know, you fit this criteria, you're probably going to need it. If the person may then go on to have a non-COVID respiratory illness, and they may or may not need care, so they kind of head off out of that patient journey at the moment, but not necessarily from the GP point of view. If they report a positive RAT or receive a positive PCR text, they then get contacted by ACT Health. They'll get their results, as discussed earlier, from the place that did their testing. Then that gets sent to us, and then we get then ACT Health does send them a text as well. In the initial text that they get from ACT Health, it's got information about where they should go, if they're unwell, the different avenues that they can access care. It's got isolation instructions, and it's got a survey to complete. In that survey, it's got some of the high-risk things that then get sent off to care at home. Working to make sure that every single person, whether they fill in the survey or not, gets the information, because they all do get an email, but sometimes we don't actually have an email address if they don't fill in the survey. So trying to make sure that even if we've just got a mobile number, that they all get the equivalent information from what's in the card, so that everybody knows that they might be in a risk category and might need to go and talk to a doctor about getting some antivirals or other treatment. We've made it fairly broad because it's not just antivirals that sometimes people need to tap into. Sometimes it's things like they're pregnant and may not necessarily need the antivirals, but they want to know what to do if they have bleeding or if they have decreased fetal movement. And that's often the calls that we get at ACT Health, because they go, I'm stuck at home and I don't know where to go or where I'm allowed to go. So if they get in touch with their GP early on, then often all of those worries settle down and they're actually much more comfortable while they're in isolation. And there's various other things. People who have carers come and visit, are they still allowed to visit? There's a lot of those sorts of questions that go on, particularly in those people who've got a lot of comorbidities. Then the person's isolating for 7 days, and hopefully they're well enough to not need to go and seek additional care over that time. I won't go through that bit through the middle because Care at Home's already talked about that. There is wellbeing support for people who, while they are in isolation, and this is nothing to do with antivirals, but just for you to know that it's there, and they can either call that themselves. Feel free to give them the number, or if you're worried about someone, you can call and say, can you get in contact with these people? We're not sure that they'll contact you themselves, and we're happy to give them a proactive call. When they're cleared from isolation, they get another message to say, if you have ongoing symptoms and you are concerned, then contact your GP. They do get given the message of, if you've got ongoing symptoms, don't go out and about in the community, even though you've been cleared from isolation. I know not everybody reads that bit, but they do get told it. And then, of course, the rest of the journey is if they have any ongoing symptoms and long COVID and things like that, which I'm not going to go into today. At the time of a repeat infection is the other time that potentially is the time to tap into. Maybe you didn't get your antivirals the first time you had an infection because you had it pre their availability, but maybe this next time is when you actually might need to get them. And that kind of takes me on to testing advice, which at the moment is quite confusing because it's also around retesting advice for people who have already had it. This is available in the information for health professionals. Actually, most things that I'm talking about tonight is in that. If you Google ACT Health COVID Health Professionals, that page will come up. We try and keep that as up to date as possible for the GPs in the community, and it tends to have contact details, testing advice around PPE and all various things in there. It's quite a long page, but it's pretty navigable. I won't go completely through this testing advice because it's there on the website if you want to go look it up. Probably the bit that's potentially that's worth looking at regularly over the next little bit is who to test within the 12 weeks after they've had an infection. And the answer at the moment is retest the people who are at high risk of severe disease where you want to give them an antiviral if it's positive, because you think they're at high risk of disease if that's a second infection. So there are a group of people who, if they're with the BA1 type of the Omicron, and they might be getting a reinfection with the BA4 or 5, and that can happen in the less than 12 weeks. And so those people who are at risk of developing that really severe disease, we want to be picking up those people now. You don't necessarily have to retest all and sundry. Everyone needs to get the message of stay home if you're sick, but they're the ones that you might want to retest, and you'll probably start getting people coming in doing that. Yeah. No, symptomatic people. Symptomatic people. Don't retest asymptomatic people. Yeah, yeah, yeah. We are getting a fair bit of retesting of asymptomatic people, and it gets quite confusing then to interpret because some places have workplace screening that we try and get the message out that you don't have to do workplace screening of asymptomatic people, and that's quite tricky to interpret if you then get a positive result, because it might just be a bit of viral, non-infectious viral stuff that's still hanging around. The other thing that's on that page, which can be useful, particularly into winter, is so not all of the testing facilities will test for non-COVID respiratory things, such as if you think it's useful to have a influenza test on that person. So this keeps getting updated as that changes, as we get information from the testing laboratories. So take a look at that if you're not sure. The thing to remember is if you're just testing for COVID, people can just rock up and they don't need a form. But if you're testing for anything else, they need a pathology form. If you're retesting somebody who's already had COVID, it's really nice to give them a form so that all that information is on there, and you can actually say, this is someone who had it this long ago, but this is why I'm retesting. We've talked quite a bit over time about how much flu is running around in the community at the moment, and straight numbers of notifications of flu is a really tricky thing to actually figure out how much flu is in the community, because this is testing patterns. And we know that we're doing a lot more testing this year than we have in any other year. This is actually this year number of test requests for influenza compared to 2019. So you can see there's a lot more testing, and so there's going to be a lot more picked up. Whether that actually means there's a lot more influenza in the community compared to 2019, it's really hard to know. And then we have to look at other things like what's happening in the hospitals, how many people are actually being hospitalised. But just to put some context around the flu numbers that you're seeing. I'm diverting off to flu now. This is also something that you can really access through the NCS website in the red there. This is flu vaccine coverage in the ACT. We are, of course, pretty awesome compared to everybody else. We always have quite good rates of vaccine coverage in the ACT. In the top couple in most of those year groups at the moment. It's actually a little bit higher than there's been a bit of a, it's gone up about 10% in the under 5-year-olds in about the last couple of weeks. So that's really good to see. Can't remember what I was going to tell you about that. Oh, I know what it was. That just shows when we're trying to, this is kind of the other preventative side of helping the healthcare system, is flu vaccination. And when we get, we can focus on the places that are already free. So everybody probably knows off by heart the National Immunisation Program, who gets a free flu. There's still room, you can see in those stats, to push people in those categories to suggest that they go and get a flu vaccine. It remains one of the biggest indicators of people getting flu vaccine is that they were given that recommendation by a trusted health professional. So continue to do that, it works. The other places, the ACT Health is, and I'm not in the vaccine team, I'm just kind of doing this for them. There's another little group of people who have been provided flu vaccines in the ACT that haven't necessarily been free before, which is people with a disability and their carers, the support workers and concession card holders. They can access a free flu vaccine through the Access and Sensory Vaccination Clinic, and there's appointments and details on the website about how that can be booked. And then down the bottom, I've just written this, where cost is a barrier to influenza vaccination. Now, you should all be getting a message about this in the next few days, but this is kind of, probably nobody else knows at this stage. There's going to be a small amount of flu vaccine delivered to each practice next week sometime, that doctors can use their discretion. If you've got people who cost is a barrier and you think that they would benefit from having a flu vaccine, you'll be able to use your discretion to be able to give them a free one, even though they don't fit the National Immunisation Program criteria. Happy to take questions on that later, but there will be a letter coming out about that shortly. This is just an ongoing message that is going to keep going out in community comms, which is about continue to stay home if you're sick is going to be the big message, and all of the other COVID smart practices around hand hygiene and wearing masks and staying home if you're a close contact and all of those things. The next couple of slides are I'm just going to leave them on for a little bit because they're just basically where you can find information. Again, once you know what to Google, you can find most of the ACT Health information by going ACT Health COVID household contacts or something like that. Will get you all of that. COVID positive will get you all of the information for people who are positive. Recovered cases is the other really key one that people tend to refer to quite a bit. And then the last thing, again, just to put antivirals in the even bigger context, is we're also dealing with all of the other diseases that don't go away. Or that start to emerge. So if you're looking for information about Japanese encephalitis, monkeypox, or the acute hepatitis of unknown etiology in children that have all recently been issues that we've had to get across, there are Chief Health Officer alerts. They're actually on the ACT Health website, not the COVID website. But if you find yourself at the ACT Health website, you can see that little blue bar, the second pale blue bar across the top, that will take you straight to the health professionals page of the COVID one, if you found yourself there and you actually wanted to go to the COVID part of the website. And I think that's probably enough for me.
So I'd like to thank all our speakers tonight, Dr. Aurora, Dr. Hutchison, Dr. Colwell, Tomika and Chloe. I hope we've given you a bit of information that's been helpful for you.